Hi, this is Kendrick with worldmedicalschool.org. Today we're going to talk about burns as part of our comprehensive USMLE Step 2 review. We're looking for volunteers that want to help with this project. At the end of the video, we'll give you a link that you can follow to get involved. So, burns are the second leading cause of death in children and still a major cause of mortality in adults. And the main types include chemical, electrical, and thermal burns. So on your history and physical, the first thing that you need to assess is whether or not they are stable. So their airway, their breathing, circulation, and then we're going to get to how much of their body has been burned, and we'll talk about how to quantify that in a second. Make sure that you're thinking of things like cyanide poisoning and carbon monoxide poisoning. So those are very common, especially in closed spaces. So first degree just involves the epidermis, and you can get a first degree from the sun, and they're generally pretty painful, but they don't give you blisters. A second degree includes a little bit of the dermis as well, and that's why you get the blisters, is because you get the involvement of the dermis in that epidermal dermal layer. So the third degree, that's when you go through the dermis all the way and sometimes into the underlying tissues like the muscles, and you get painless, white, or charred areas. And the reason they're painless, of course, is because we burn the nerves. So to assess the area of the body, we use the rule of nines. So how much of the body has been burned, and we'll show you a little bit more about the rule of nines in 1 second here. And some labs you might want to order include carboxyhemoglobin, but in general we're not going to be waiting for this to come back anyway before we treat for possible carbon monoxide poisoning. So it's kind of just a confirmatory test. Chest x-ray will help us to assess how much damage to the airway we might have. So the rule of nines, just like I promised, is right here. This breaks up the body into numbers divisible by 9. So each arm is 9% of the body. The front of the thorax is 18%, as well as each leg is 18%. Then the back of the thorax is another 18%. And I've got 1% for the neck here. You also see 1% for the perineum. I don't know, if you add those together you get 101%, so I'm not sure which one of those you should use, but probably isn't going to make a big difference. So, and the only modifier to this is that women with large breasts, especially larger than D cup size, they're going to change this by up to 5%, so you might want to just look up some charts for that. Another thing that you can use for smaller burns is the palm of the hand, including the fingers, is 1%. If you don't include the fingers, it's just the palm, it's 0.5%. So that will help you to assess how much body surface area you got burned. For imaging, we talked about chest x-ray, but you also want to rule out associated trauma. And you can do bronchoscopy as well to assess for inhalation injury. So when do you want to transfer these to a burn center? Well, I've seen a few different statistics or a few different criteria to use, but a full thickness burn over at definitely over 10%, but maybe just over 5% of the body area should be transferred to a burn center. This one is questionable. Partial thickness over greater than 10% of the body area. Certainly this wouldn't include a sunburn that includes the back and shoulders easily getting over 10%. But another number I saw here was partial thickness or any thickness over 25%. And then burn of critical areas like the face, hands, feet, genitals, perineum. you want to make sure that those are taken care of at a burn center, just to make sure that people are not disfigured and they don't lose function in those areas. High voltage and chemical burns should probably be taken care of at a burn center, and those that are complicated by trauma or serious inhalation injury should also be taken elsewhere. With treatment, everybody needs fluids. You lose a lot of fluid when you get burnt, and you continue to lose fluid. So the Parkland formula is the weight in kilograms times the percentage body surface area that's burned, using the rule of nines, and then you times that by 4. So I am about 80 kilograms, and if 25% of my body were burned, that would be, okay, now I have to do the math here. That would be 2,000 milliliters, and then you times that by 4, I would need 8 liters given in the first 24 hours. So I'd give half of it in 8 hours. So in the first 8 hours, I would get 4 liters. And then in the second half, I would get over the next 16 hours. Of course, you want to make sure that you treat the pain and the anxiety that's associated with this. Compartment syndrome is a serious challenge here. And so you need to be ready to do fasciotomy to relieve compartment syndrome. And then wound management, generally you're going to want to debride the wounds. We'll talk about that in a second. Cyanide is a real concern. Hydroxycobalamin or amyl nitrate, sodium nitrate, and sodium thiosulfate can be given. It sounds like the new recommendations are starting to lean toward hydroxycobalamin alone. That's what they've been doing in Europe for a while, and it seems like the safety rating is really good on it. Carbon monoxide, treat with 100% O2. Rhabdo, make sure you're maintaining the urine output over 100 cc's an hour, and debridement is important here. So debridement consists of getting rid of all the bad skin, all the dead tissue. And one of the important reasons we're doing that is because of the possibility of infection. So dead tissue is a great breeding ground for infection. Pseudomonas is the classic one that you think about with burns. It could be any type of infection, though. It could be staph, strep. So make sure that we're getting rid of the dead tissue. There's been a question about giving oral antibiotics with this, or IV antibiotics, and there hasn't been any proof that helps prophylactically, but certainly once somebody's infected, you can give antibiotics. Skin grafting is an important part of regaining function and cosmesis. Autograft means you're taking skin from another area of the body. You use a little what is it called? A dermatome? I can't remember. You use a little slicer that cuts off a little layer of skin, and then you transfer that to another part of the body. Allograft is from another individual. Postoperative complications include infection. You need to worry about nutrition with these people. Certainly the psychosocial issue is a big one here. A lot of people come away from burns very disfigured, and that may be the hardest challenge in their life afterwards. Marjolain's ulcer, as we have pictured here on the right, is a skin cancer that can result from the scarring after burns. So something that you want to keep an eye out for because it can be pretty dangerous. So thanks for our picture of Marjolain's ulcer by Raj, and for the other pictures we used here today. If you have any questions or if you'd like to volunteer, please go to worldmedicalschool.org/volunteer, and we appreciate all your comments and sharing the videos. Thank you very much.
A 69-year-old man presented with a 25-year history of gradual, asymptomatic thickening and wrinkling of the skin on the left side of his face. The physical examination showed hyperkeratosis with accentuated ridging, multiple open comedones, and areas of nodular elastosis. Histopathological analysis showed an accumulation of elastolytic material in the dermis and the formation of milia within the vellus hair follicles. Findings were consistent with the Favre-Couchet syndrome of photodamaged skin, known as dermatoheliosis. The patient reported that he had driven a delivery truck for 28 years. Ultraviolet A, UVA, rays transmit through window glass, penetrating the epidermis and upper layers of dermis. Chronic UVA exposure can result in thickening of the epidermis and stratum corneum, as well as destruction of elastic fibers. This photoaging effect of UVA is contrasted with photocarcinogenesis. Although exposure to ultraviolet B, UVB, rays is linked to a higher rate of photocarcinogenesis, UVA has also been shown to induce substantial DNA mutations and direct toxicity, leading to the formation of skin cancer. The use of sun protection and topical retinoids and periodic monitoring for skin cancer were recommended for the patient.